Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
You know that feeling in the clinic? It's 3 p.m., you're running behind, and you have a patient in exam room 2.
Mm-hmm.
They are just miserable. Burning, regurgitation, maybe a chronic cough that just won't quit. I mean, it looks like GERD. It sounds like GERD.
Right.
They've been on omeprazole for 3 months. Maybe they've even doubled the dose, but they're still suffering. Or maybe they're young and just tired of taking pills. And inevitably, the conversation pivots to the S word.
Surgery.
Surgery.
And it is a massive pivot. I think we sometimes minimize it, but we aren't just talking about titrating a dose here. Crossing that bridge from medical management to surgery is a profound physiological shift. You are permanently altering the anatomy.
And that is the friction point, isn't it? Because historically, I think there was a tendency maybe 20 years ago to just...
Oh, absolutely. See a hiatus hernia on a scope and say, well, the plumbing is loose, let's go tighten the valve.
Exactly. But today, looking at the data, we know that's just way too simplistic. We're not just tightening a valve. We have to prove the disease actually exists before we touch it.
Precisely. We are moving away from what I call anatomical surgery and toward precision physiologic surgery. The days of assuming heartburn automatically equals a Nissen fundoplication are, or certainly should be, over.
So that is our mission for this deep dive. We are unpacking the physiological evaluation, the clinical indications for antireflux surgery.
We're going to look at the green light criteria.
Right. How to objectively confirm GERD, how to catch the mimics like achalasia, and how to tailor the wrap based on pressure data.
And we'll be pulling from the heavy hitters today, the Lyon Consensus, the British Society of Gastroenterology Guidelines, and the latest data on high-resolution manometry and pH impedance monitoring.
Okay, so before we scrub in, I do have to state the mandatory disclaimer. This content is for reference only. Please always follow your local guidelines and protocols in clinical practice. This is about understanding the physiology, not replacing your hospital's SOPs. So let's start with the candidates. The WHO, I think there's a lingering misconception out there that if a patient has heartburn, they're a surgical candidate. But the surgical pool is actually much smaller, isn't it?
Oh, much smaller. And far more specific. If you operate on the wrong patient, you're setting everyone up for failure. Generally, we're looking at 3 very distinct buckets of patients.
Okay.
The first is the most straightforward. Documented GERD with inadequate control.
I want to push on that phrase, inadequate control. Are we talking about people for whom PPIs do absolutely nothing? Because if the PPI doesn't work, does the surgery even work?
That is the classic question, right? Usually, inadequate control means they have a partial response. They might have their heartburn under control. The chemical burn is gone, but they still have volume regurgitation.
So they bend over to tie their shoes.
And gastric content comes right up. PPIs change the pH of that stuff, but they don't stop the volume. And if that volume is disrupting their quality of life, that's a strong surgical indication.
Got it. Then there's the second group, which I find the most interesting. The PPI-dependent group.
Yes.
These are often younger patients, right? Maybe 30, 40 years old. They feel fine on the meds, but they're looking at 50 more years of daily therapy.
That is a huge driver. They're worried about the long-term data valid or not on bone density, renal issues, all of that. For these patients, surgery is essentially a pill substituting therapy.
But there's a catch.
A very big one. Because their symptoms are well controlled, you have a much higher burden of proof.
Because you're taking a person who feels totally fine.
Exactly. You are taking a healthy person who is symptom-free on a pill and exposing them to surgical risk. You have to be absolutely certain the physiology supports the diagnosis. If you get that wrong, you've done harm for zero benefit.
Okay, and then the third group, the complications. Erosive esophagitis, LA grade C or D, strictures, Barrett's.
Right. And for strictures especially, if a patient keeps getting them despite high-dose acid suppression, just dilating them over and over isn't a strategy, it's a Band-Aid. Surgery is often needed there to stop the underlying drive.
And we can't forget the big anatomical defects, the large sliding or paraesophageal hernias.
In those cases, you're fixing a mechanical defect, but you almost always add the fundoplication to restore that reflux barrier.
Okay, so those are the green light candidates. Let's talk about the danger zone. The extraesophageal symptoms, the chronic cough, the laryngitis, the asthma. I feel like this is where clinicians can get into the most trouble.
This is the graveyard of surgical success rates.
Okay.
I cannot stress this enough. If you operate on a cough based on a hunch, the outcomes are incredibly unpredictable. The placebo effect is massive, but long-term resolution is often poor.
So no correlation, no operation.
That is the safest rule. You need robust, objective evidence. A positive pH impedance test that specifically shows a correlation between the reflux event and the cough event. If the numbers don't link up, surgery is a gamble you shouldn't take.
So let's talk about getting those numbers. The truth serum of this whole process, 24-hour pH monitoring. I'll play devil's advocate. Why isn't the endoscopy enough? If I see a red, irritated esophagus, isn't that GERD?
You'd think so, but the sensitivity of endoscopy is actually quite poor. We have this massive entity called NERD, non-erosive reflux disease.
NERD. Yeah.
And up to 60 or 70% of patients with pathological reflux have a completely normal-looking esophagus on a scope. If you rely just on the visual, you miss the diagnosis.
And conversely, a red esophagus could be eosinophilic esophagitis or pill-induced or...
Exactly. Redness is subjective. We need the physiological data. And the real game changer here is impedance.
Explain that, because standard pH just measures acidity, right? Is the pH below 4?
It's binary, acid or not acid. But reflux isn't always acidic, especially in patients on PPIs. The refluxate might be pH 5 or 6. It's weakly acidic. Or it might be non-acidic gas. Standard pH misses all of that.
So the patient says, I'm regurgitating. The pH probe says, no acid. And the surgeon implies, it's all in their head.
Exactly. Impedance fixes that. It measures changes in electrical resistance. Liquid conducts electricity well, gas does not. So it detects the volume movement no matter what the pH is.
That seems vital for that inadequate control group we mentioned.
It is mandatory for them. If you're testing a patient on LEM therapy, you absolutely need impedance. Otherwise, you are flying blind.
Let's get into the weeds on the metrics. We have the data back. What are the magic numbers?
The primary metric, the gold standard, is acid exposure time, AET. This is the percent of time the distal esophagus is exposed to a pH less than 4.
And what's the cutoff?
According to the line consensus, an AET greater than 6% is pathological. That's a confirmed red light for the esophagus, meaning confirmed disease.
And on the flip side, under 4% is normal.
Right. Everyone refluxes a little bit. A burp after pizza is not a disease. Under 4 is physiological.
But there's a gap there between 4 and 6%, the gray zone. That seems like a diagnostic no man's land.
The gray zone is where the art of medicine really comes in. An AET of 5% is inconclusive. You can't make a surgical decision on that number alone. You have to do what we call a composite assessment.
So you look at other things.
You look at the number of reflux episodes, baseline impedance, and most importantly, symptom association.
The SI and SAP scores, this is basically trying to connect the crime to the suspect, right?
That's a great analogy. The symptom index asks, of all the times you felt heartburn and pressed the button, how many of those times was there actually acid there?
And if you press the button 10 times and the pH was normal every single time,
then you have a negative association. And that is a huge red flag against surgery. If the reflux isn't what's causing the pain, the surgery won't fix the pain.
Okay, a practical question that always comes up. Do we test them on their meds or off their meds?
The guidelines are actually quite clear. It depends on the clinical question. If it's unproven GERD burning, but no prior positive test, no esophagitis, you must test off FPPIs. Hold them for at least 7 days.
You want to see the baseline physiology unmasked.
Correct. You want to see how bad it really is. However, if they have proven GERD, say, grade C esophagitis in the past, and now they have symptoms despite medication, you test on PPIs. You're trying to see if the therapy is failing.
So unproven equals OFF. Proven but refractory equals on-an.
That's the rule of thumb.
Okay, so we've done the detective work. pH monitoring confirms pathological reflux. We have the green light on the disease. We book the OR.
Not so fast. We know they need surgery, but we don't know if their esophagus can survive the surgery. And this is where the biggest disasters occur. We have to consult the roadmap, high-resolution manometry.
HRM. This measures the pressure and coordination of the swallow. What's the number one objective here?
Ruling out the imposter.
Which is?
Achalasia.
Achalasia can mimic GERD.
It mimics it perfectly. Patients report regurgitation, chest pain, dysphagia, but the physiology is the exact opposite. In GERD, the valve is too loose. In achalasia, the valve won't open.
So if you take an achalasia patient whose valve is already failing to open and you do a Nissen fundoplication,
you're tightening a valve that's already stuck shut. You are creating a complete obstruction. It is a catastrophe. The patient will have severe, intractable dysphagia. Operating without manometry in this day and age is just negligent.
Wow. But manometry isn't just a stop sign. It also helps us tailor the surgery, doesn't it? It tells us how to wrap.
Exactly. We look at peristaltic reserve. Does the patient have the strength in their esophageal body to push a bolus of food through a newly tightened valve?
I remember the old dogma was weak peristalsis means a partial wrap, a toupee, or a door. Is that still the consensus?
It's evolving. The historical view was weak pump equals loose wrap. But newer evidence suggests many patients with minor hypomotility can actually tolerate a full 360-degree wrap just fine.
But there's still a risk.
There is. Low contractile reserve is still a risk factor.
Yeah.
So it informs the consent process. You sit the patient down and say, look, your pump is a bit weak. We can do the full wrap for better reflux control, but you have a higher risk of temporary swallowing difficulty. It allows you to tailor the strategy.
Okay, so we've gathered all this intel. We have the symptoms, the scope, the pH data, the manometry. Let's synthesize this into the decision matrix. What does the ideal candidate, the true green light, look like?
The ideal candidate has the Holy Trinity. 1, troublesome symptoms that impact quality of life. 2, objective pathological reflux. That means an AET over 6% or clear grade C or D esophagitis.
And 3.
And 3, acceptable manometry, no achalasia, and sufficient peristalsis to handle the wrap.
If you have those 3, you can proceed with high confidence.
Very high confidence. Those patients generally report satisfaction rates of 90% or higher.
Now let's flip it. What is the hard red light? When do we pump the brakes and say surgery is not the answer?
The biggest red light is functional heartburn.
Let's define that. This is the patient with burning symptoms, but
their endoscopy is normal. Their pH test shows normal acid exposure, AET, less than 4%. And, crucially, they have a negative symptom association.
so they feel the burn, but it is not caused by reflux.
Correct. It's visceral hypersensitivity. Their nerves are over-interpreting normal stimuli. Surgery does very poorly here. You cannot operate on a sensation. You wrap these patients, and they will likely still have the pain, plus new side effects like gas bloat.
That is a difficult conversation to have. The patient is convinced they have reflux. They feel the fire.
It is, but you are protecting them. They need neuromodulators or cognitive behavioral therapy. They do not need a Nissen. Operating on functional heartburn is how you create a failed fundoplication patient.
And obviously, a major motility disorder like achalasia is a red light for standard surgery.
Correct. In those cases, you have to completely rethink the strategy.
This discussion really highlights that we have moved way past the era where you just look at a scope and book a case.
We have to. The goal is integration. You integrate the symptoms, the anatomy from the scope, and the physiology from the pH and manometry. It protects the patient, and honestly, it protects the surgeon from performing a procedure that won't work.
It's not just a technical exercise, it's a decision-making process based on hard data.
That's the key takeaway. These tests, pH monitoring, HRM, they aren't just administrative hurdles. They are safeguards. They are there to prevent surgical failures that were actually diagnostic failures from the very start.
That is a powerful distinction. A diagnostic failure leading to a surgical failure.
And this precise approach lets us help the people who really need it while saving the functional patients from an unnecessary procedure.
Before we wrap up, I want to go back to that gray zone again. We talked about the black and white cases. But that group with an AET of, say, 4.5 or 5%, that still haunts me a little.
It is the most challenging group in foregut surgery, no question.
It just highlights that even with all this technology, there is still an art to interpreting the patient's story against their physiology. It's not just a spreadsheet, it's a person. How do you weigh a borderline test against a miserable patient?
That is why the multidisciplinary discussion is so important. You get the gastroenterologist, the surgeon, the physiologist in a room. The data guides us, but clinical judgment still steers the ship. Sometimes you operate in the gray zone, but you do it with eyes wide open and with very, very careful patient counseling.
Well, that brings us to the end of this deep dive. It's a fascinating area that really bridges the gap between internal medicine and surgery.
It's one of the few areas where physiology and anatomy intersect so critically.
If you found this deep dive valuable for your practice, please share it with at least one colleague or friend today. Getting this information out there really helps everyone make better decisions.
And don't forget to check out our YouTube channel and other social media pages. We have some great visual breakdowns of the manometry tracings we discussed. Seeing the difference between a normal swallow and achalasia really brings it all to life.
Thanks for listening, and we will catch you on the next deep dive.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.